Well, thanks for that introduction. Yes, I am Rich Bernard, a board certified pathologist and serve as the COO for Precision Epigenomics. We offer the EPISEEK test, and we're going to be talking about it a little bit more in detail. So, probably the most important thing to talk about is the results and the test itself. So, there are logistics involved that I really want to make sure people understand the results, what they mean, what they don't mean, how to explain things for shared decision making or supported decision making with patients. So let's get started. So the real problem we're trying to solve here is cancer, and it's an enormous problem. So in the US alone, more than 2 million new cancer diagnoses each year, more than 611,000 deaths each year. It's extraordinarily expensive, has an enormous impact on patients' own finances as well as the healthcare system itself. But if we look a little bit more closely, you can see the real problem isn't so much the cancer burden, which is enormous, but it's that late detection. When we're diagnosing cancers when they're early, the 5-year survival is better, the costs are better, there's less suffering, less mortality. But really, the problem is that we've got all these late diagnoses. So we have maybe only 14% of new cancer diagnoses are being discovered through screening. Most of the time, people are presenting with advanced stages of cancer when they've got signs and symptoms. So really what we want to try to do is get these folks diagnosed earlier so that we end up with people not being diagnosed 2 years from now, say with stage 3 or 4 cancer, but hopefully this year with stage 1 or 2 cancer and have much better outcomes. So unfortunately, the current state of screening is not that terrific. I mean, we've made progress, no question, but things need to change. So in terms of, excuse me, I'm sorry about that. So the goals of a cancer screening program, what are we trying to accomplish? So cancer screening wants to identify patients who have cancer. We want to detect it earlier, again, to get that benefit of diagnosing earlier at a lower stage. We want to reduce the chance of bad outcomes, whether it's morbidity or mortality. And then the test itself has to have more benefit than harm. In other words, if it's extraordinarily expensive and nobody can afford it, that's not going to be effective. If it has too many false positives and lots of folks are getting worked up to see if they have cancer, that can be very expensive. If it doesn't diagnose cancers early enough, that can be problematic. And again, if it results in lots of invasive biopsies and harms being done to the patient, again, that's not going to be effective screening for our purposes. So in the US currently, we have screening in place, but really it's only for these 4 cancer types. So for breast, there are imaging studies, whether it's mammography, ultrasound, or MR. For colorectal, oftentimes endoscopy, but also fecal testing. There's also a single cancer blood test that may be available soon. And then lung is important as well. And these are for high-risk folks. So most people should not be getting lung screening each year. It's really for folks that have a strong smoking history, as you can see here. But currently, I'd say that the programs we have are pretty good, but they're not terribly effective. They tend to underperform. If you look at the top, this is an American Cancer Society graphic. On the top, you can see for men and for women, the new cancer diagnoses each year. And then on the bottom, you can see the cancers that are actually killing patients each year. So if we focus on that, you can see that uterine, cervical, or Pap testing doesn't show up on the list because it's not one of the top 10 killers. But you can see that lung cancer, breast, colorectal show up. Prostate's kind of a special consideration. PSA is still being done, but it's not routinely recommended. So in special circumstances, if it is done, it used to lead to biopsy right away. And now the thinking is maybe we're finding too many early indolent prostate cancers that may not have injured the patient at all. And by finding these early cancers through biopsy, we're actually ending up with more harm than good in terms of the number of men that are being affected with big surgeries, big therapies that are maybe resulting in impotence or incontinence for a small indolent cancer that might not have harmed the patient anyway. So prostate is kind of a special matter. Our solution was to develop an assay to detect lots of cancer types with a single test. So currently we have one screening test for one cancer type. And the problem is we don't know which cancer type we're going to get in advance. So you can be very diligent about getting your colon screening, but more likely than not, if one of us is unfortunate enough to get cancer, just on the odds, it's probably not going to be colon cancer. It's probably going to be one of the other cancers that are, in aggregate more common. So our approach is a single test to detect all the cancers with one single test. And the way it works is that if there's a small cancer, say growing in the lung, even when it's a stage 1 cancer, as it's growing, it's releasing abnormally methylated DNA or DNA that's wadded up inappropriately. And that's what kind of is a hallmark for the cancer signal. And we don't see that in normal tissues. So these little fragments of abnormally methylated DNA are released out into the bloodstream. We're able to detect those by using phlebotomy, maybe once a year, taking a sample of blood for the EPISEEK test. It's peripheral phlebotomy, taking that and look for these little fragments of abnormally methylated DNA. And what we did is we looked at the Cancer Genome Atlas and looked at thousands and thousands of cancers and figured out, well, what's the least common denominator? What's almost always abnormally methylated in cancer, but not hypermethylated in normal tissues? And then we developed probes against those sites that we've patented and use those to identify these little tiny fragments of circulating tumor DNA or cell-free DNA. Um, Again, if you've got your patients to the point where they're actually taking the assay, fantastic. If not, and they're still deciding on it, this will help understand the process a little bit better. So let's say that the peripheral blood has been collected, it's 2 tubes of blood. We encourage these to be collected on Monday through Wednesday, typically. If we get a Thursday afternoon phlebotomy and the FedEx guy has already come, it might not get picked up till Friday. And then it might not make it to a lab on Saturday, depending on delivery services. So we really want to get the specimen into the laboratory, ideally the next day. 2 days is also acceptable, but just be aware of holidays and Thursdays in particular. People can get sideways with that. We don't want that to be a problem. But the specimen comes to our laboratory. We get it into our system through our laboratory information system, give it a unique identifier. We centrifuge the specimen down to separate the plasma, which is what we're most interested in, and less so the red cells and the white blood cells. We want those to not be part of the process. We're looking for cell-free DNA, not DNA that's in the white blood cells, for example. So following centrifuge, we'll take that specimen, we'll do some modifications in the laboratory to it to help expose those abnormally methylated areas and make it easier for us to identify them. We'll put the specimen on our PCR instruments, and PCR instruments are, and this will be important later, but PCR instruments are scalable. There are a lot of these instruments globally, and cancer is a global problem. So we really wanted to have a global solution that's affordable, fast, reliable. And that's one of the reasons we picked the PCR platform. At any rate, the results will come off the instruments. We have a trade secret classifier that looks at the PCR outputs and determines, is this within the normal range, what we see in people that don't have cancer, or are the outputs on the other end an abnormal methylation signal detected, which is often associated with people having cancer. So all in all, within about 5 days, typically, it'll probably get faster, but for today, we're saying about 5 days, the result should be available. And if there is an abnormal result, which is by far the exception to the rule, but if there is an abnormal result, we will reach out to the clinician directly so that you're not in a position of, okay, I've got an abnormal result. What are my next steps? We want to make sure that neither the patient nor the healthcare provider that ordered the assay is in a position of, okay, now what do I do? I have this abnormal result. So just recognize we're here for you and we can help with follow-up. So how does the test do? Does it detect a lot of cancer types or not many? Well, good news is you can see again the incidence on top are the new cancer diagnoses each year for men and for women. And then beneath that is the fatality for men and women. And suffice it to say that yes, the EPISEEK assay detects all these cancer types. It does detect additional cancer types too, such as stomach, uterine cervix, although PAP testing is doing a great job. It does detect uterine cervical cancer, plasma cell myeloma, and other malignancies as well. The more testing we do, the more cancers we add to the list. So this will continue to grow. What about the performance? It's one thing to say it detects those cancer types, but how well does it detect it? So let's talk about the overall performance first. So I want to start with a positive predictive value. And cancer is not a terribly common disease out there and everybody walking around. So the positive predictive value is going to be really important. So right now, the positive predictive value is 40%, and that's comparable to another assay that's very similar to ours. in terms of how the assay performs. If you compare it to something like mammography, it's actually terrific. The mammography positive predictive value is maybe 8%, 6 to 8%. In other words, mammography is good at finding lumps and bumps, but only 8 or 6% of the time is it actually a cancer that needs to be really taken seriously, but it needs to be worked up. And that's what a screening test is supposed to do. It's supposed to identify the folks that need additional workup and separate the folks that don't need to be worked up additionally. So our positive predictive value of 40%, what does that mean? So if we take the next 5 abnormal methylation signal results or the abnormal assay results from our laboratory, we take 5 of those. 2 of those are going to get worked up, maybe PET-CT or MR, and they're going to see, oh, this patient has cancer. For 3 of those patients, they might get a PET-CT and some routine screening if they haven't been up to date on that, and cancer will not be found. So 60% of them, they won't find cancer, 40%, we will find cancer. Now, of those 60%, it remains to be seen if those are false positives. In other words, the patient did have a very small malignancy that was not detected immediately, but we do tend to wait 12 months to make sure the patient hasn't presented with malignancy. And if they haven't, then we will go ahead and consider that a false positive. So that's how the positive predictive value works. The negative predictive value is a little bit different. This says if we put out a negative report, in other words, no cancer signal detected, what are the odds that the patient does not have cancer? And for this, it's 99% essentially. And what that means is that a test is not 100% perfect because we've said that it isn't perfect on detecting all cancer types. And so there will occasionally be a false negative, and that's what that negative predictive value is about. Let's focus a little bit on some of the targeted cancers, and I'll show you these in just a minute. But the reason we developed this assay, if you think back about those ACS graphics that show the top 10 cancer types, some of those we don't have any screening for at all. So think about, liver, think about pancreas, the stomach, esophageal. These are bad actors, and they tend to have a very poor 5-year survival. Brain cancer, I didn't mention, but that's another one that has poor 5-year survivals, and we don't have screening for it currently. So we identified those as our target cancers. And we said, look, for stages 1 and 2, which is really what we care about, getting it before it's spread to lymph nodes, before it's gone distant, what is the sensitivity? How good is it? Well, currently it's 0% because we have no screening for esophageal, gastric, pancreatic, liver, brain. So currently it's 0, but for stage 1 and stage 2, it's at 57%. So that's pretty good. Right now it's 0 and we go to 57%. For higher stage cancers, of course, it does better, but that's less important because at that point, the cat is out of the bag. The tumor is already spread either regionally to lymph nodes or distant metastases with stage 4. So it is of some value, but really our focus is getting those stage 1 and stage 2 cancers. And right now it's 57%. So what about specificity? The specificity has to do with how well does the test put out a normal result if the patient doesn't have cancer. So let's say there's 100 people in a room, and we know absolute truth that all 100 of them do not have cancer anywhere in their body. There is a 1% chance that our assay is still going to identify one of them as having an abnormality. And that, again, harkens back to why we don't have a perfect positive predictive value. There are going to be some abnormal results, but almost always, if the patient doesn't have cancer, the result will be a negative. So this is a little bit more detailed, and I think this really helps kind of explain what I was talking about earlier. You can see the list that we call our target cancers here. And if you focus on that second set of bars where I've circled 57%, that's, again, currently we're at 0% for those cancer types in terms of screening. And this is 57%. So again, pretty good in terms of the sensitivity. If we look at all the cancer types, including cancer types that are less fatal, but maybe more common, things that are more slow growing, including the other cancer types of all kinds, the sensitivity is at lower, maybe a third almost. But still, it shows strong performance. So again, the purpose of our assay was to identify these aggressive, bad cancers that don't have great screening currently. And again, you can see the list there. The assay is not perfect, though. So different cancer types have different amounts of cell-free DNA. A few slides ago, I talked about the abnormally methylated DNA being released from the tumor cell and floating around in the blood. Well, it turns out that prostate cancer, for example, does not release very much circulating tumor DNA as a rule. So the other assays that are out there as well, just like ours, tend to underperform. It's not a great assay for prostate, but it more, in my view, makes up for it in some of the areas where we don't have screening, such as pancreas, liver, esophagus, stomach, kidney, and colon, things like that. So I do want to make sure that you and patients understand that this is not a perfect test. It's designed to identify folks with cancer at early stages. It does a pretty good job at 57%, but when we do adjustments for what cancers are out there, you just need to keep this in mind as well. So cancer signal not detected. This is by far the most common report that you're going to see because number one, most folks don't have cancer. And again, because our specificity is set pretty high. So we're going to not have a lot of false positives out there. But cancer signal not detected, I just want to make sure people understand what this means is that, having this means that the patient does not have cancer in their body at this time with a very high degree of likelihood. It does not mean anything about what's going to happen next year or the year after. So this is not a risk determination test that you're unlikely to develop cancer in the future. It's, do I have an unknown cancer hidden inside my body at this time? So that's really what this is designed to do. And as I mentioned on the previous slide, it's not a perfect assay. So people need to continue with their current standard of care screening that they think is appropriate for them in discussions with their healthcare provider. So maybe it's breast imaging of some kind, maybe it's fecal testing or endoscopy, maybe it's pap testing, low-dose CT if there's that smoking history. We don't want people to stop getting routine screening done. And that's one of the reasons that we want healthcare providers to be involved in the process, to make sure that folks understand this and continue. This is our abnormal methylation signal detected. And probably most importantly, you'll notice we don't say cancer signal detected. Some laboratories take that approach, but again, even knowing that they're more likely than not the patient doesn't have cancer, with a positive predictive value of less than 50%, didn't make sense for us to say cancer signal to get people worried about cancer because, again, this is a screening test. We have not made a diagnosis of cancer. We don't make a diagnosis of cancer with this EPISEEK screening test. We want to identify folks who are worthy of additional scrutiny, additional examination, getting additional imaging, getting caught up on screening if they're not caught up, maybe some additional chemistries, proteins, for example, if you're thinking about myeloma, maybe additional laboratory testing. And that's really the focus of this, is to identify folks who need additional workup, not to make the diagnosis. So again, this makes it more likely that someone who has this abnormal result will have cancer. It does not mean that they have cancer. So we do not say abnormal methylation signal detected. If you do get one of these results on your patients, I'm going to say almost, you will be contacted by one of us in our laboratory. We will reach out to get additional history. Does this patient have an interesting history that maybe didn't make it onto the requisition? Is this truly a screening case where the patient has no signs or symptoms but has this abnormal result? One of us will be in touch with you so that you fully understand the implications of what this is and what to do next. And this is usually more than just a one and done type phone call. There's usually an exchange of ideas, and we want to consult and support you as you manage patients that have these abnormal results. So in summary, I just want to say the EPISEEK assay being PCR based has extraordinary sensitivity in my view. I think it can do a lot of good. It is a scalable solution. This is a global problem, and we want to make sure that this scales effectively across the globe. It's not just a Western problem for people that can afford expensive testing. It really is something we want to get in front of as a company. These normal assay results mean that it's very unlikely that the patient has a hidden malignancy, but we do want to continue with that routine screening. The abnormal result, we will call you and work through it together. Typically, that means a PET CT scan, additional studies to look for the malignancy. But again, recognize that there will be false positives. In fact, probably more false positives than true positives. So don't let folks get too anxious and excited about the abnormal screen. Again, it's just to look closer and make sure that there's not a hidden malignancy because, 40% of the time we will find one. So we just want to make sure you understand the limits of the test. And I think finally, this is essential to longevity and wellness. If we're serious about taking care of people and giving them healthy, long lifetimes or health times, this has got to be part of the solution. And I think multi-cancer detection, detecting all these different cancer types with a single test, once a year is going to be very, very helpful for patients and for the providers that are caring for them. So again, my name is Richard Bernert. You can get in touch with us through the website. There's a contact us form. I'll be delighted to speak with you if you want to chat. But again, thanks so much for your time and thanks for listening.